See, I'm not going to try and talk to you. So far so good. The pace, not too bad. We're going to move on now. We finish the diagnosis, we finish the treatment planning. We now want to start moving into our cases now. So if you have a chance, when a patient comes and see you, you look at a tooth. The tooth cannot be saved with a crown or a root canal, then it has to be taken off. Then you have the chance now to decide what to do with the tooth. A lot of the times, patients will come to see you with the tooth already lost. But if you have the chance to manage the broken tooth, this is a good chance because you can make your patient's life easier when they want to have implants later on. My topic for this afternoon, we talk about how do we manage hopeless teeth. When we talk about a hopeless tooth, or what we call an unsalvageable tooth, there are many reasons why we cannot save the tooth. So if it's a mechanical reason, because of some problems, you see, fractures, or is it biological, a disease? For mechanical problems, you have a root fracture, like I said again, in Singapore, I see one case a week of a tooth fracture. And usually I like to do my own kind of extractions. Because I like to control how the thing looks like, do socket preservation, preserve the bone, and then come back in 3 months. Sometimes you have perforations, can you see this? No? Sometimes this happens. Sometimes it's the problem of the dentist, so we need to understand, right? But cases like that will happen and then the tooth cannot be saved again. You have situations looking like that where the tooth is completely gone and then the caries are even more subgingival. Can you do a crown lengthening? I say no. What other problems we have? Gum disease. Okay, gum disease is something that I see every day, so and it's very difficult for me to manage my patients. Why? When my patients come and see me for gum disease, already they lose papilla, already they lose bone height. So a lot of the times, my implants end up having a possible black triangle. Correct? Charlie, I think this one is flicking too much. So it's very, very difficult to manage gum disease because, look at this. You already have a black triangle there. So the patient needs to understand that once in a while, full trap, black triangle is to be expected. And if you see a situation like that, see, look at the bone loss, almost 70 to 80%. You've got to start thinking, do I just take out the tooth like that, or do I do something different? It gets worse and worse. So a lot of the times when we learned, you take out the tooth, let it heal by itself, what's going to happen to this? What's going to happen to a situation like that when you take the tooth out? It's going to have a big hole. The body cannot repair by itself so much. So sometimes we have to help. Okay? So in cases like that, sometimes you have to tell the patient, I need to do step by step. If you can do socket preservation, good. But if you can't, then everything is very delayed. Come back for a block graft 3 months later, 6 months implant. The patient needs to understand. Caries, we see caries every day. Okay, how do we want to manage them? I like to treat my patient with what we call an infection control phase. You cleared all the disease, caries, endo, perio first, before you start on your implant planning. We talk about root resorption. This can actually happen. So it makes the teeth hopeless or unsalvageable. When you have a tooth taken out, and when you have a tooth taken out wrongly, and the patient ends up having a severe bone or soft tissue defect, you can get complications. You have complications from speech, okay, phonetics. You have complications from function, which is the normal biting and chewing. And if your implants are in the front, it's definitely an aesthetic problem. Okay? What do I mean by this? Take a look at this. Huh? Because just like George Clooney, remember the dentist that treated him? If you do not take the tooth out, because for me in dental school, for the 3 of us in dental school long ago, How do we take the tooth out? What do? You put your foot there on the patient and you pull it out. Yes? Maybe, no, maybe not. But that's how we do. You just, in dental school, and then you take it out, and the professor could take, because the tooth is taken out. But that's wrong. Because you destroy the bone, you destroy the soft tissue. Then you end up in a situation looking like that. It's very difficult to manage. Or a situation that looks like this. This looks a bit red. Do we have the technician? Maybe they can adjust the projector. Extraction socket changes. When we take the tooth out, or when someone takes the tooth out, the socket will change. Previously, when I was in dental school, we didn't even care. Because why? So what? When we start doing implants and we start dealing with aesthetics, we need to care because the socket sometimes shrink more, sometimes shrink less. We need to understand why. Can you check the photo? It looks very red, too bloody, like a horror film. Not so red, a bit pink. Yeah, thanks. Nightmare.
Saw 5.
Saw 28. Is this okay, guys? A little bit better. But not the best. Or you like this? Is this better? You think? Okay. You stick with this. Thank you. Sorry, the projector is not from Straumann. So when tooth is taken out, you have to expect changes. Okay? Point number one, we'll go a little bit more in detail. When a patient sees you for a problem, when a patient sees you for an extraction, does he come to your clinic, hey doc, can you pull this tooth, good tooth out for me and put it in implant? Will he do it to you? There must be a problem. What kind of problem? Infection, trauma, blah, blah, blah. So already there's a problem. So can you imagine you pull out a problem tooth, the socket healing is not so ideal. If you were to do an orthodontic case, and you pull out a premolar, which is nicer, the healing is actually quite good, right? Because the tooth, it's not decay, caries, gum disease, right? So point number one, you get infection or trauma. Point number two, things change when you take out, okay? We'll talk about that. And number three, the facial bone wall is usually very thick, okay? And this has been shown in studies, in animals and in humans, okay? We just talk about humans, and we don't talk about animals. It's our patients and all that. Chronic infection or trauma. They have shown in studies, okay? So this was done so long ago, almost 20 years ago, in a private practice clinic, 100 patients that come into the clinic for extractions. They want to know what kind of anatomy the socket is. They found out that out of the 100 cases, 50% have an intact wall. What does this tell you? The remaining 50%, the wall is already broken. Why? Because of infection, because of trauma. See? Right? So the percentage is about there, maybe 40 to 60%, it depends on your clinic. Okay? But studies already show that, maybe 50% of the time, then you get a nice wall. So you see, already you're not in a good position. We have seen in research, we have seen in studies that when the wall is intact, when you have a nice 3-4 wall defect, okay, the blood vessels will nourish the socket. You have stem cells, growth factors, bone cells coming in. That's why in an intact socket, the healing is very good as compared to a broken socket. When you have a defective socket, the studies have already shown that more resorption on the facial bone. Okay, this is research. Research has shown this. Intact socket heals better because better vascularization, better blood vessel healing, better growth factors because there are more bone walls. And if you have a defective socket, we've got more resorption. When we have resorption in the socket defect, and when it's time to place in the implants 3 to 4 months later. This is what happens when the socket doesn't heal so much. You end up having peri-implant defect. Okay? So I will tell you how to analyze this defect, but these are all aesthetic cases. This is not the time for it. I just want to tell you how the extraction socket heals. A lot of the time, extraction socket doesn't heal completely. Okay? Now, in the old previous way, when we see a defect socket like that, we cannot put in an implant. Before, the old theory is that you have to have good bone. But now we know it doesn't matter anymore, because with the best bone, with the best implant systems, okay, you can actually put it in and do bone graft and it will work. Okay? For the aesthetic sites, we do it the next time when they come in. The other kind of peri-implant defect is that the crest is intact. Can you see? Dehiscence means the defect starts from the top or from the crest down. Fenestration defect comes from the word Fenster. It's a German word for window. So it's a window defect. Can you see? So the crest is intact, but they mean the same thing. Change number 2. Physiologic change when you take the tooth out. Okay? Physiologic means natural. That means you and I can't control. It's something that is like a genetic, DNA. You resorb more, you resorb less. This is the diagram that I drew. Okay? So I'm not very good with, right now with digital stuff. So it took me one whole day to draw it. I'm just kidding. So this is a nice socket. Okay? When the tooth is present, okay, I repeat again, when the tooth is present, you have this very thin bone inside that calls bundle bone. This bundle bone in dental anatomy is tooth dependent. So if you have a tooth, you have bundle bone. No tooth, no bundle bone. What does this mean? It means that if you take the tooth out, this whole bone will disappear straight away. So that's why you already lose. Okay? Now, that's point number 1. Point number 2, in the mandible, in the maxilla, the tooth is always positioned slightly towards the buccal. And because of that, the buccal bone is generally thinner than the lingual or palatal wall. So if you think about it, if you think about this, when I take the tooth out, and the tooth is slightly positioned more buccally, and if the bundle bone is uniform or consistent, what would happen? It means that after healing, the remodeling would show more bone loss on the buccal. Does it make sense? Because your tooth is now shifted this way. The bundle bone is now closer to the buccal bone. So when you lose that, you see more changes in the buccal side. And where is the most important side? Buccal or lingual? Always buccal, right? Aesthetics, everything. Recession. This came from this particular study, okay, in the States. So they looked in Snoopy dogs, the legal dogs. They did studies. This is a very important study because when they look at dimensional changes of a tooth extraction, they found out that in day 0, and 2 weeks, and 4 weeks, and 8 weeks, you see where the buccal bone slowly it starts going down and down, down, down. When they start looking at lingual bone, see where the lingual bone is. Lingual, 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 lingual. See, the lingual bone doesn't change so much. Okay? That was in dogs. In humans, the same thing. They did studies. They found out from the buccal point of view, the vertical bone loss is about 1 to 2 millimeters. So you lose the height. And then the horizontal, buccal lingual, you lose about 2.5 to 5 millimeters. That's a lot. These are physiologic change. That means nothing is, they did extraction in all these patients and then they measure. This study, very long ago, almost 15 years, they found out that the first 3 months, already 30% change, shrinkage. At 12 months, it's about 50%. So a lot of the bone change, a lot of the physiologic change happens when? In the early phase, the first 3 months. Okay? I will teach you concepts how to control this, because this change you and I can't control. It's a natural process. What does this mean? It means that in 12 months, we lose half of the crestal bone dimensions. What does this mean in our clinical practice? It means that on the day of extraction, patient has a broken tooth, 1-1. Okay? 1-1. And then you take the tooth out. You try to take it out. Very easy. And then you measure buccolingual. 1 centimeter, 10 millimeters. What does this study tell you? This study tells you that if you don't do anything at all, you just leave it alone. After 12 months, you want to put in an implant. What is the width? 5 millimeters. What is your bone diameter? 4 millimeters, regular. You see? Tricky, huh? Some case more, some case less, huh? Because this is average. So you already see, it's not easy. It's not easy. This came out from an ITI group. So they studied different publications out there, and they found out that 32% of bone loss occurs at 3 months. So very close to this study. So you know, different part of the world, they are collaborating, and the story is the same. Rapid bone loss occurs in the first 3 to 6 months. So this is the critical time point. What does this tell you? That this tells you that if you want to do implants after extraction, maybe you might want to put it around the 2nd to 3rd month first. If your patient can't afford, or the patient has no time for you, what does this mean? You need to do something different. What? Socket preservation. You see now why we are doing this for certain cases. Okay? Is it because I say so? No, because of research. You have to use research to clinical practice. The last category of extraction socket healing that is going to impact your clinical practice is that we know right now that the facial bone wall is very thin. And because of that, you're going to see a lot of shrinkage. And you know that if you put an implant in, what do we say in the beginning? How much bone you need to have around the implant? At least 1 millimeter or more. So it impacts. What does it mean in clinical practice? You have to tell a patient that you have to spend money on GBR. Not, hey, you need the bone graft right now. You have to plan beforehand. We have seen in clinical studies, okay, that for the anterior, especially the aesthetic zone, okay, we'll stress this more in the next lecture, that you need to have at least 2 millimeters of bone, even more, for your really fantastic aesthetic result that I show you. The posterior, sometimes a bit of recession, we don't care. This study by docs say that 2 millimeters or more reported less bone resorption around implants. Another study in Japan, Miyamoto and Obama, not the former president, but he suggested that if you have more than 2 millimeters of bone in front of your implant, you have maintained long-term tissue stability. The 2 millimeter keeps on coming up for implants and aesthetic sites. So maybe for the front, you need more bone. This picture was taken from one of Professor Booz's lecture. Some cases you have more than 1 millimeter thick, which is great. Some cases you have none. And if you have a case that has trauma or infection, I expect it to be none, right? 50% of the time you have less than 3 bone wall defect. Remember, we saw that research. So it's not easy, just pulling out the tooth. You need to start thinking what you want to do. Okay? There was this study that looked at immediate implant placement. And what they did was that without using CBCT, they took the tooth out and then they raised a bit of a flap. They used the bone calipers and measure. They found out that 88% of the time the bone is very thin, 1 millimeter. So can you imagine you take the tooth out, that 1 millimeter is going to disappear because your bundle bone is about 0.8 already. Yeah? So very thin. Another study from Professor Booz's group in Switzerland, 125 patients, 500 teeth. So they measured what is the thickness of the buccal bone. Same thing, 88 to 90% of the time, less than 1 millimeter. Very thin. Not easier. So what about Asians, right? I always talk about, we have to look at some of our own population here. So we have seen Hong Kong, Singapore, China, we have done some research, and we are almost the same as the Caucasians, very thin bone. So what can we do now? Wow, stop doing implants. So difficult, right? What can we do is to have a strategy, to have good knowledge, and comes with experience, right? So we need to analyze the defect first. We need to make sure that these implants are in the correct three-dimensional position, and of course use the best implant materials and bone graft materials. When we look at defects, when the implant goes in on that day, we like to have this kind of bone walls, if possible. The bigger the bone wall, the better, right? As I said before, intact. So in the ITI classification, they grade it as grade 1, where you have very nice bone. Okay? You see this a lot in immediate cases. But be careful of immediate implant placement, because immediate implant placement means the tooth is just taken out. What you are seeing is not the final shape and the volume, right? Because the changes occurs at the first 2 to 3 months. Grade 2 is a little bit less bone, but still the implant is mostly covered. Grade 3, less and less bone. You see the dehiscence even more, but still we get good results. When we start moving to grade 4, it's too flat. We can't even put in any implants at all. So that's when we have to stop and do a stage GBR. Okay? So like I said again, best will be grade 1, not so good will be grade 3, but grade 1 to 3 kind of bone situation is good. If you see a situation where the bone is very flat, then you have to decide, can I put in an implant? If you only want to put in a regular size implant, then I say no. You stop, you do a stage GBR. Sometimes when you think outside the box, I put in a narrow implant. So you choose a reduced diameter, right? Because when you choose a smaller one, it becomes quite a nice defect size, right? But you can only do this in certain brands of implants. Why? Because if you put a small implant over a big head, it will fracture. That's why Straumann came out with the rock solid. So we talk about that in a later part, where I will show you some of my successes. So the Straumann brand basically will help you in cases like that where patient cannot afford extra GBR, for example. What else? Patient cannot do extra surgery, those medically compromised, and you want to just open or flatless, put in an implant, and then that's it. These are good indications, and you choose a small diameter implant. But your implant must be of a good quality. Robust, doesn't break under pressure. So there's an increasing trend now to use narrow diameter implants in a very severe range, okay? But not all cases. We have to check occlusion, blah, 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 everything else. So when we do this, it's very easy. You convert the defect into something that you can manage. The purpose of the narrow implant is to create a more contained defect. Okay, so previously the implant body goes all the way out like that, but if you choose a smaller implant, it becomes more inside. You can do GBR. So, how to minimize problems when the tooth is in front of you? When the patient sees you for a hopeless tooth, you have a chance right now to make your life easier. You can minimize the chance of getting a stage 4 kind, or grade 4, where the bone is so thin. You can minimize that. Socket preservation or site preservation is one technique for you. Okay, it's very, very useful. So the definition as such is the maintenance of the hard tissue and the soft tissue. Because I showed you that an extraction socket will shrink. If you have an infection and a trauma, it's already broken. If you have physiologic ridge changes, it's already going to shrink. And then more so, the bone, the buckle is very thin. So you've got 3 things against you. And you haven't even started yet. When we look at extraction sockets, when we pull this out, okay, the mandible or the maxilla consists of 2 kinds of bone in the anatomy. Okay? The alveolar bone, where it holds the tooth, and the bottom is called the basal bone. When there's no tooth there, the alveolar bone will slowly disappear. First the bundle bone, and then slowly it starts resolving more. That's why you see some old people, when they have extractions right now, Everything is all very sunk. The mandible is so thin. Because you know what's left? It's only the basal bone. Very, very difficult to treat. Again, we go back to studies. So in the same group in Sweden, they did the research in dogs. So they found out what happens if we put in some bone graft material inside. Can we slow down this process? 5 dogs, split mouth design. Who can tell me what split mouth? Does anyone know what split mouth means? Split mouth means in research, left side of the mouth you do treatment A, right side of the mouth you do treatment B. You don't want to make it too random. Because if, let's say, one dog is crazy, at least the crazy dog has a treatment A, treatment B. You understand what I'm saying? You want to reduce the error. So left side of the mouth, socket preservation, right side of the mouth, no socket preservation, and then they check. Look at this diagram here. So in the non-grafted side, wow, look at the crest, 30% bone loss. Huh? This is what we discussed, right? The crest shrinks so much after 6 months. Look at the grafted side, 3 times less. See, 36% and 12% is 3 times less. What can we learn from this picture over here? What can we learn from this table? Okay? When you read articles, you need to read it and understand, because sometimes the authors do not mention everything. It's too long. I learned 2 things from this table. Who can tell me the 2 things? Just try. I'm trying to teach you how to understand research and article. This is one very easy thing to understand. Number 1, my conclusion is if you graft, you get 3 times less resorption. Yes? But there's 2 other hidden messages inside this. What is the first message? The message means that even if you graft, you still lose 10%. You see? Yeah? So with whatever bone graft that you use, even if you place it inside, you cannot think that you preserve 100%. You shrink, but you shrink only 10%. Yes, less. So you cannot tell the patient you preserve 100% of bone, because this is not right. Okay? This is the hidden message number 1. What is the hidden message number 2? Hidden message number 2 is that look at the middle and the apical part. The middle and apical part, look at the resorption pattern. Not much difference. So a lot of the times the changes happen where? At the crest. Because our bone structure is always like that. It's smaller at the crest and then it gets wider. You see now? Okay? And which is the most important part in terms of success or aesthetic success? At the crest. Right? Always at the crest. So the results or the conclusion for this study was that the bone graft does not make the bone any better. You know what's the best bone graft in the world? The patient's own bone, if you ask me. That's the best bone graft. Because all this bone graft you put inside, the inside it's not so nice bone. It's an augmented bone. It's a filler. You put like plasticine inside. So the bone formation, there's no improvement. Okay? But because the bone graft is stuck inside, the remodeling cannot shrink so much. You see? And then you preserve the bone for a delayed placement, 6 months, 12 months later. When we put the bone, the 3-dimensional profile of the socket is well preserved. This is what we want. So that was in dogs. What about in humans? Because every time in research, we always have to look at animals and humans. So this group over here in Zurich, Switzerland, they look at 40 patients, 4 groups. So first group is beta TCP. Second group, we got this cow material. And last group is no graft at all. They found out that if you were to use a bone graft inside, it has less vertical and horizontal changes. But again, this picture shows that even with the tip, you see, there's still about 5 to 10% bone, or 70% at the crest. Even with the best bone grafts, you're going to expect some resorption at the crest. Without bone graft, it's 40% from this study. But it doesn't mean that with the bone graft, you're going to get 100% preservation. It doesn't work that way. But sometimes you have to grow more bone. But this means that you can place the implant ideally. Okay, so now we want to do socket preservation. Is it something that is practiced here? Were you taught about or you heard overseas in the lecture about socket preservation? Is it something that, is it common? Do we do it here a lot in Yangon? Not so much. Not so much. I would like to share with you this technique because it makes your life easier. Socket preservation is basically pull out the tooth, slowly put something inside, and then you wait. Okay? When we do that, okay, we do it for several reasons. If you want to delay the implant placement, if the patient cannot afford your money now, if the patient is traveling overseas, or if the patient is too scared of surgery, or if the patient smokes too much or has diabetes, you want to delay the implant placement 1 year later. If you don't put anything inside, what's going to happen? 50% of the bone at the crest will disappear. Right? It's going to make your life difficult. So you have to think, implant is going to be placed so late, I put in something right now. So timing is one criteria. Pontic site development. What does this mean? When you want to do a 3-unit bridge, maybe not even an implant. And it is in an aesthetic zone. You pull it out, it will shrink 50%. But if you put bone there, wow, the pontic looks nice. So you use it for prosthetic reasons, not necessarily implants. When I do socket preservation, I need to have an absence of any acute infection. Take the tooth out, and if it's bleeding with pus, do you want to put a bone inside? No. The foreign bone will get infected. So this is my next SL active question to you. Okay? I'd like you to think out of the box. If the patient comes to see you for a tooth 1-1, and it's very difficult, in biotype high smaller or very tricky, very demanding. You want to do socket preservation for this case, but the patient comes with a slight abscess, and you want to take the tooth out, but you know that you can't put in the bone. What do you do? Who can give me a solution for this? Huh? Root canal first to get rid of the infection. What else? But the problem is that what if we can't do root canal? What can we do to make the situation to your advantage? Remember, the tooth is infected, you get an abscess, and then when you move the tooth, there's pus coming out. Wow, you know that you want to do socket preservation, but you can't. What can you do? Control the infection by antibiotics. You change the nature of the infection. So I give strong antibiotics and I wait 1 week later. When the patient comes back, you change the acute infection into a chronic infection. You see? You take the tooth out, maybe not so bad. Yeah, you curette the socket, all the granulation tissue, put in the bone. And you see? Tips and tricks. You change the profile. I do this quite often sometimes. Because you really want to put something inside. Well, obviously, the second time round with antibiotics, if it doesn't work, means it doesn't work. Then you have to take it out, wait 3 months, and then you do a stage GBR, blah, blah, blah. Okay, but you try. Acute infection. So if there's acute pus and acute pain, forget it. Because otherwise, you are making the problem even worse. Your defect size has to be mild to moderate. What does it mean? It means that, maybe a little bit of buccal bone loss. Because if the defect has no buccal wall at all, no matter what you put in, it's not going to work. Okay? It has to be a reasonable defect, like a bowl. So like a rice bowl, if the bowl is a little bit broken, you can still contain the rice. But if the bowl is completely gone on one side, you put the rice inside, it comes down. Same thing. So your defect must be medium size or less. If your socket wall, especially in the molar side or the premolar, is very, very thick, like 2 millimeters, then sometimes you don't need to do anything. Because it's a nice intact socket. So you choose your area. But these are the main selections. Okay, so I'm going to tell you what you do. Step by step, you want to take the tooth out, low trauma. Low trauma extractions, you curette the socket, you investigate the socket, you think whether you want to put in a bone graft, and then you close. Step number 1, we use periotomes. Have you heard of this before? Yeah? Charlie, does Goodon Smith have periotomes? Because if you don't, you need to have this. Now, this is not elevators. These are not luxators. So periodontists like me, very sensitive, very soft. I like to do things very slow. Okay? I always make fun of my oral surgeon because they that's it. So when I came back from the States, in Singapore, they didn't have periotomes. So I bought my own periotomes, put it in my luggage, and I brought them to Singapore. Then I donated to the clinic in a hospital. So the periodontist will do it very slowly. And once my oral surgery failed, everything is all bent because they got this like a couplet. So it's not a couplet, it's not a luxator, it's not an elevator. It's more for, it's like a thin blade. It's in and out. It's to cut the PDL fibers. Okay? So you put 15C inside, you remove the crestal fibers, and then you go in and remove the PDL fibers. Okay? It takes a lot of time, right? If you can do it flapless, that will be ideal because you have less trauma. Okay? But if you can't do it flapless, that's okay. Right? Don't worry, this is not my patient. This is a dental skull. So you have the anterior is straight. So you go in and out, you cut the PDL fibers, and then on the palatal, you do that. If it's in the molars, you have a contra angle. Can you see that? Like a 45 degree. Then you go in. The same concept. The purpose of the periotomes is to cut the PDL fibers. It takes a lot of patience. Because if you're someone who's very impatient, you just do it one round and then it doesn't work out. Then after that, you start using the fine elevators or the fine luxators. Slowly you go in and then you start. Never do it on the mid-buccal. Again, mid-buccal at the crest is your critical site, right? Especially for aesthetics. So I like to do it mesial-distal or from the lingual. Because if I need to damage something, I'll damage on the lingual or palatal. Okay? So you loosen it with your fine elevators, and then slowly, what I like to use is what we call the apical retention forceps. Okay? Now, the traditional forceps that we learned is like a parrot, the beak is like that. These forceps are different. Can you see? The beak is not one point, it's the whole length. So what it does is that the pressure is not there. So it's very easy. I like this for extractions. Okay, we call this apical retention forceps. Alright? And then you rotate it. Now, if we are dealing with a molar or a multi-rooted teeth, you cannot do this because you fracture everything. If you are dealing with a multi-rooted teeth like a molar, maxilla and mandible, you have to start sectioning them. There are many ways to section. Okay? This is one way. You get a burr inside, you remove the 2 buccal roots. Okay? And then you preserve the bone walls. Remember? The bone walls. If you can't do that, then what I would do is that I will get a high-speed burr, like cutting the crown crab. Okay? High speed with a diamond burr. If it's on a lower molar, mesial-distal root, I just section in the middle at the furcation and I break it. So you end up having a molar to now 2 premolars. Can you see? You're making your life very easy. And then the extraction is very atraumatic or low trauma. So I would get my high-speed handpiece and I'll just break the whole thing. From furcation to the end, buccal to lingual, just break it. Okay? You have to break the furcation. Then you get a luxator and then you split it up. Then you take out 1 tooth at a time. Very easy. Trust me. Okay? And then, yeah. If you are dealing with an upper molar, it's very different. There are 3 roots most of the time. Okay? And then what you have to do is that I section from mesial to distal. Okay? And then I make a small cut here. Then I'll have 3 separate roots. and then I remove it individually. Trust me, when you try this, it makes your life so easy. Okay, now the tooth is taken out, right? You have done a low trauma extraction. And what you need to do is, all the infection, the foreign bodies, you got to take it out. Granulation tissue. Okay, the basic principle of any wound healing is that you need to see blood. Okay, blood is your friend. Good blood, not the infection kind of thing. So you want to scrape and scrape until you get hard bone. You know, like when they did cancer treatment, when they did a radical, they have to remove the cancer and some good tissues. It's almost the same thing. You have to scrape onto the bone. Sometimes I run the burr to create some nice bleeding in the bone so that the blood is fresh. And then you evaluate the socket, point number 3. You investigate whether you are the good 50% where you have intact socket or the not so good 50%. You have broken socket. Yes? Why I say this? Because in an intact socket, what you do is that you use the bone graft material of choice, you put it inside, and then you put a sponge on top, and then you suture. Figure of 8 for the cross stitch, that's it. You have done your socket preservation. If your socket is not intact and you have a funny socket there, then you need to do a minor GBR. You take a small little membrane and then you tuck it inside here. Can you see this? And then you put your bone graft. It's like a broken rice bowl. You put scotch tape at the side, and then you put your bone inside. Okay? Can I show you some exciting example of how this is so easy? Huh? You know, it will change your life really. So I start from the easiest to a crazy case. Huh? Then you see that I'm not too bad. My skill. Case number 1. A lady came in with a cracked tooth. We did low trauma extraction, and then she said, "Doc, it's very painful right now. Let's take it out, but I can't see you for the implant because I'm going back to London to finish up my studies, but I'll come back in 1 year's time." So I said, "That's fine. Let's take this out, clean everything up, put in the bone." Huh? Exactly like what I thought. So we go in, try to do it flatless. We put in the bone graft, and then we put a sponge on top. Now the sponge can be anything. I do not know what they have in Yangon, but in Singapore they have collar coat, collar plug, Surgicel, something collagen, very cheap. Basically, it helps as a blood clot. And then 1 year the lady came back after finishing her studies. I looked at it, I was like, wow, it's so easy. And I even did it almost flatless. This is how the implant looks like. Huh? Yeah, this one. Okay? I didn't have to do anything. So you kept the situation very easy. Because after 1 year, we can expect about 50% bone loss at the crest. So you minimize that. I took a CBCT, I said like, wow, the crest looks great. Huh? I don't even need to do GBR. 20 minutes, this patient was out of the chair. Okay? Contact site development, second indication. Indicated in patients when they decided as a fixed bridge, okay? Because you want to have a nice contact emergence. I can do it with implants, implant bridge, and I can also use it for the conventional bridge. And then, of course, your contact needs to be ovate, like a little oval. Okay? It cannot be like a rich lab and that kind of thing. It has to come out quite nicely. So let me show you a case. This is very interesting. You remember this lady who was referred to me with a broken 1-1, and then the dentist said, take out 1 tooth. I said, no, we take everything out. Okay? We analyze the situation, and we say that we're going to do 2 implants at the lateral incisor, 4-unit bridge retained by 2 implants. And because there's only 2 implants, there's going to be 2 pontic sites. So I think, okay, let's just preserve the pontics with socket preservation. So we took the tooth out, okay, everything. This happens to be a very nice lady who sings in a choir. She's the lead singer in the church. So without teeth, it really impacts her a lot. Huh? So this is something, that you really want to help her. So to cut the story short, we put in bone graft here, okay, and then we put the collagen sponge there. And this is how it looks like, 10 days. We haven't placed the implants yet. Okay, this is how it looks like. on the day of the implant placement. This is a very good example because why? The lateral sides, look at that, the resorption is already happening at 8 to 10 weeks. But look in the area where I did socket preservation. It's not too bad. Huh? It's still soft. The bone inside is soft, but you have preserved the ridge. Can you see that? This is a very good example. Why? Because here and here, I did not do any socket preservation. Here and here, I did. Okay? Of course, I placed Straumann implants inside. This is the tissue level, and we close it up. But this is how it looks like. Wow. You know, when you like beef, you know, I love my beef steak. This is like a nice beef. So nice and juicy. So you know these kind of cases is going to come out quite nice. You see, 7.5 years, we take a CBCT, the bone is there around your implant. But not only that, these are the extraction socket sites, the pontic site development. See, the bone is still there. Yeah, it's not bad, huh? So patient got the teeth back, but it took a while, right? Socket preservation, implants before you can get the final restoration. Sometimes almost 9 months, 6 to 9 months. So it takes a while. 10 years. Because she brushes so hard, you see, you get a little bit of recession. But by and large, not too bad. Huh? Patient is very, very happy. So she sees me every 6 months. Talking about pontic site development, I got a third case for you. This is a very young guy, 17-year-old. Okay, so he rides his rollerblade, got into an accident. So he had trauma, he had cracked teeth. We took the tooth out, low trauma, and we did socket preservation. We planned for the implants at a much, much later age. Why? Growth. There are many reasons why you delay implant. Money, going overseas, scared of surgery, medical problems cannot solve. The other reason is growth. Okay, it's a medical legal problem. It's a medical legal problem if you place implants before they finish growth. Okay, because puberty, the structures are still growing. Because everything moves down except the implant. The implant is ankylosed. Okay, implant is ankylosed. Boys, they finish puberty late. Girls, they finish puberty early, right? We all know that boys, you know, they remain like kids. Even right now, my wife says I'm so childish. So I think I haven't finished puberty. So I cannot place implant. So it's a general profile that ladies, they finish growth by about 19, 20. Guys, 21, 22. The only way to confirm is that sometimes we send these young patients to the medical hospital and take two kinds of x-ray, either the lateral ceph to look at the bone fusion or the hand wrist radiograph. Then you ask the radiologist there whether the fusion is complete, because if they are complete, it means that they have stopped growing. Okay? So this guy cannot have an implant until 3 to 4 years later. I need to do something for him. See, he already fractured this, huh? So we put in the bone, put in the sponge, and this is what we did. We did a cantilever, temporary bridge, a provisional. This is how he lived for 4 years. Not bad, right? You kept the bone there. Huh? So one way, you know, to help you, to help this patient. Because if I didn't do anything for this case, if he comes back 4 years later, what's going to happen? No bone. You got to take bone from the ramus chin. Very, very tricky. Next case. 10 years of socket preservation. This lady said, Dr. Yo, I can't afford your implant. Too expensive. So I said, why don't you wait 1 or 2 years? I put in something inside for you. She waited 10 years. Huh? Really? Luckily, my cost didn't go up. So, we put it. You see the bone graft there? Inside? The bone graft does two things. I realized. Firstly, it preserves the bone. You know why? This case was picked up not by me, by my student. So my student said, hey, Dr. Yo, you did socket preservation 10 years ago. You want to see? Oh, I got so excited. I said, let's take a photo, but you have to do the implant properly. So I had to stand there and make sure that she puts nicely. When we open the flap, look at the bone, 10 years, it didn't change. And the other thing that socket preservation does is that it maintains, it doesn't really tilt so much. That's what I feel, adjacent teeth. Because the bone is so tough, the bone graft. Very, very interesting. So this case, we put it in very nicely because I told my students, I said, you have to put nicely, you know, otherwise I can't take the photo and show it to my friends. Imagine the implant is like that, and I was like, forget it. And this is how it looks like. Wow, this is my 10-year case, man. Wow, interesting. It really preserved. Next case, case number 5. This guy is an elementary school teacher. He smokes, but he has a perio-endo lesion. You see? Perio and then endo, tooth is non-vital. And then it started moving out. See, it starts tipping out. But you look at his occlusion, it's not simple. He has a very deep overbite. So I said, okay, let's do this. So we follow the socket preservation technique. Low trauma extraction, periotomes, and then we clean everything up, put the bone graft. Okay? And then we gave him a denture. And I came back in 3 months. But at 10 weeks, we took a CBCT. You see, we lost some bone at the crest, but mostly we can preserve quite a lot of the structure. Okay? To cut the story short, this is how he looks like. Not bad, right? See? 3 years, this is the tooth. You look at the bone at the front, nice preserved. Case number 6. This case here, you have gingivitis. It's a joke because it's a gingerbread man. This case is one of my most severe site preservation case. Okay, I was just trying it out because I wasn't even confident. This lady is a hygienist. So she's a hygiene student, graduated, is a hygienist. And basically, she works in an orthodontic practice. Her boss is an orthodontist. And the boss said, let me charge you 50%, I'll do the braces for you. But this is how it ended. You know. Unfortunately, sometimes things go wrong. We have a situation looking like that. I was like, oh my gosh, this tooth is not vital, right? So it has to come out. The prognosis, you know, there's no bone all the way to the apex. The buccal bone is gone. Tooth is class 1 plus almost 2 mobility. If I were to take this out, ladies and gentlemen, what's going to happen? The whole bone is going to collapse. Wow. So I have to start thinking, I said, oh my God, oh my goodness, what am I going to do now? And I help this really young girl, only 25. She has a very severe bimaxillary. So that's why when the orthodontist tried to push the tooth in, the root came out, you know, and then that's it. You have this dehiscence. So I said, okay, let's stop. We have to take the tooth out, but we want to manage this maybe with socket preservation. I do not know whether it's going to work. So we took the tooth out, and you can already appreciate it. The whole thing is gone. But I decided to do something very different. So this is where my perio skills come in. We did fine surgery. We did a split thickness pedicle flap, and then we swung the whole thing. You know? It's like a seesaw, brought it over there to cover. I repeat again, we took the keratinized tissue from this side and we push it towards where the bone graft is to create a new soft tissue. And this is what we got. Wow, not bad. Huh? We managed to cover it at 1 and 3 weeks. Huh? And then at 2 months and 3 months, you know. So we changed from a very severe situation into something, you know, a complex situation under SAC. I call it SAC plus. It's a C plus. I change it down now to an A. Well, it's not so simple, but I changed it to advanced by doing this technique. This girl, she graduated. She went to Australia, Adelaide, to continue her dental. She wanted to be a dentist. So now she went there, and I'm just waiting for her because I really want to take the CBCT and see what kind of before I did the implant. So this is still, we have to wait. So socket preservation, guys, they are very, very useful, really. They are going to help you, not only you, but for the patient. I do it not in all cases. I have some indications. Uncontrolled medical problems like diabetes or smoking, you want to delay a little bit, you put something inside and then you wait. I do it in age. We talk about age. You can't do it in patients who are still growing. So you have to hopefully retain the bone. Patients who are indecisive, and this is a very good so-called practice builder. Because every patient you want to hopefully give them the best. And they can't afford right now, you say, never mind, we just wait. Okay, because this lecturer, patient waited for 10 years, it's going to work. You just wait 1-2 years, you have enough money, and you come back, we'll do the implant for you. This is a nice case. If you want to do pontic sites, even if it's a bridge, a conventional bridge, this is going to look nice for an aesthetic site. In cases that have very high aesthetic demand, I like to put something inside. Okay? Because if you remember my cases, the WTF moments, sometimes I take it out and then it doesn't heal. Why? Maybe because the previous infection was, or the PA lesion was so severe that the bone just doesn't come in. So sometimes, in a very demanding case, I just put in the bone graft to help me heal at the bottom. Then I can put an implant inside and then I have some OGVR. Okay? Again, this is a separate topic for part 2. I do it in cases where you have an extended timing. Delayed placement approach, age, delayed placement. I do it because I like to reduce the invasiveness for future surgery. If I can avoid a block graft, I will do it. Right? Because it makes your life very easy. Because otherwise you have to refer to the hospital and get an oral surgeon to do it. But by doing it, you control and you keep the patient with you. Okay? So with that, I think I'm almost done. I share with you some remaining cases. This is another one that had no bone at all, and we did socket preservation. You see the amount of bone that we kept after 2 months. Okay, and this is another case where you have multiple extractions. It's important that you realize that when you take out multiple teeth, I'm going to show you an example with this diagram over here. When you take out multiple teeth, you're going to end up in a situation like that. Correct? So if you're taking out multiple teeth, it's nice to do socket preservation to help to minimize the shrinkage. But can you minimize 100%? Can you get 100% bone? No. We learn about this. All right. So with that, I'm done with the site preservation technique. If you have any questions for me? Because I'm hoping to do it for the next round where we are looking at getting thick jaws. Then you will practice with a high-speed curve how you section, because these animals, they have premolars that are bifurcated like molars. You learn how to section them, you remove it, and then you put in the bone, and then you suture. So hopefully we can get that. But this is something you realize. Is it helpful, you think? Not too bad. Any one of you does socket preservation before? Yeah, you do it? So it's something new. But it's interesting. And it has been going on for a long time, almost 20 years. Almost 20 years. It just helps you for your patient. Okay? Any questions? Anything? Charlie, do we have a short break or? Okay. So we have now, we spoke about this before, how the tooth behaves inside the alveolar bone, right? Again, the same thing as I mentioned earlier today. In the maxillomandible, okay, the tooth alveolar concept is made up of 2 parts. It's the alveolar bone or the alveolar process where it holds the tooth, and the basal bone. Okay, this section over here is entirely tooth dependent. So first the bundle bone disappears. And if there's no bone over there for a long time, the bone at the top over here starts to decrease until you get only the basal bone component. Okay? And then if you want to do implants or even a denture of it, that's why people with dentures keep on changing it. You have to change it every 3 to 5 years. So the anatomy looks like that. Okay? The histology, when they do it, the bundle bone is actually under X-rays the laminar dura, it's like the white color space that you see here. That's the bundle bone. It's tooth dependent, you extract it, it disappears. The bundle bone is about 0.5 millimeters, So if your buccal bone is only 1 millimeter or 0.8 and you lose that 0.5, it's going to be so thin. Huh? And it starts disappearing at 6